All right, welcome back, and this is part 4 of 4 in the ECG series. And in this section, we're going to talk about heart blocks and other conditions with ECG findings and basically some remaining topics that don't really fit in any other section. So in terms of blocks, let's start out talking about the bundle branch blocks. We have two different types, just to sort of break it down into broad categories. We have right bundle branch blocks and left bundle branch blocks. Now, if you remember the bundle of His, as it approaches the septum, it divides into the right and left bundles. The left bundle also splits into the anterior and the posterior fascicles, as shown here in this image. This is the anterior fascicle and this is the posterior fascicle. And they provide essentially conduction to the septum of the heart. Again, the Purkinje fibers are given off the left bundle starting at the base of the heart and off of the right bundle at the apex of the heart. Whenever there is a block in the bundles, that means that there's discordance between the depolarization of the right and left ventricles. And so that often results in a widened QRS because when one bundle is knocked out, the other one will conduct normally to its respective ventricle. And then the current will travel through a more slowly through a more, lesser velocity through the myocardium, through the actual muscle of the heart to the other ventricle. And this results in a widened QRS. There are some other findings which I've listed here as well that help you decipher if this is a right bundle branch block or left bundle branch block, or if there's an anterior, left anterior fascicular block, so on and so forth. So let's go through some of these. So for a right bundle branch block, the diagnostic criteria include what we typically say are rabbit ears. Just to make it easy when you're initially learning them, but the more correct way to say it is RSR prime. And notice that the first R is lowercase. It means that the first R wave or positive deflection is smaller than the second R wave, which is larger in uppercase, and we call that R prime. So we have a RSR prime in V1 through V3. The QRS width should be greater than 120 milliseconds. And the width of the S wave in the left-sided leads in limb lead 1, AVL, V5 and 6, the S wave should be wide and deep. And then the other sort of key finding is that in a right bundle branch block, the R prime is taller than the first R, which is the small r here. So the way that I remember that is that the R wave on the right side in a right bundle branch block is taller. And when we talk about ventricular tachycardias, sometimes that helps us differentiate between SVTs with a right bundle versus a true ventricular tachycardia. So this last point here is actually important to remember. In a left bundle branch block, the diagnostic criteria, again, the notched rabbit ear, or more correctly, the RR prime. So there is no S wave, that's why there's no RSR, it's just an RR prime. And they're typically of equal height, so there is no difference in putting the lowercase or the uppercase here. And these are seen on the lateral lead, so 1, AVL, V5, 4, 5, 6. The width of the QRS should obviously be enlarged or widened as well, greater than 120 milliseconds. And in V1 and V2, on the right-sided leads, you should see a dominant S wave. And actually, this is called a QS wave, and it's a very wide, and you'll see in the examples, this is probably the most striking thing that we look for or that we see first. That makes us think that there's a left bundle branch block, and then the notched rabbit ear or RR prime, if you will, that's sort of like a secondary finding oftentimes. But to break it down and make it simple, when you're looking at a 12-lead EKG and you look at the precordial leads, if you see this quote-unquote rabbit ear on the right-sided leads, this should make you think right bundle branch block. If you see the rabbit ears on the left-sided leads, it should make you think left bundle branch block. So that sort of breaks it down and makes it easy. And again, the widening of the QRS and the multiple R waves is due to one side of the conduction system, one bundle conducting normally, and then the electrical depolarization traveling more slowly through the myocardium, through the muscle that has the lowest velocity, over to the other side and causing a more delayed depolarization. So the left anterior fascicular block, this is the left anterior fascicle comes off of the left bundle. So sometimes you can have a block of the left anterior or the left posterior fascicle as well. So what you should look for is a right bundle branch block pattern, so RSR prime in V1 through 3. And whenever you see that right bundle branch block pattern, look for the axis. If the axis of the heart is a left axis, there's left axis deviation, there is also a left anterior fascicular block. Okay, if there is a right axis deviation, then there is probably a left posterior fascicular block. So the bottom line is, whenever you see a right bundle branch block pattern on ECG, look for the axis, because there may be also another anterior or posterior fascicular block. This one here, I didn't know where to put it, but an SA node block, essentially a long pause or asystole after a normal sinus beat rhythm. It may pick back up with normal sinus again, or it may cause an escape rhythm or an escape beat, which is shown on the bottom image, which is a PVC here. So let's do a practice question. We'll pause the video here and take a few seconds. Okay, so what does this look like to you all? Again, using limb lead 2, you look across and you see if there are any P wave activity at the baseline. This is obviously widened. Is it tachycardic? Is it not tachycardic? It doesn't appear to be very tachycardic. We can try to calculate the rate here, 300, 150, 175. It's somewhere around there, so it's not tachycardic, but it is a wide complex dysrhythmia, if you would. So just looking at this, the most striking thing is on the right-sided leads, we see these deep S waves. And that's what I mentioned is the most striking thing when you see a left bundle branch block. And then we can confirm that by looking at V5, V6, and do we see a widened QRS with what looks like a rabbit ear, like a notched rabbit ear, RR prime finding, and we do see that here in V6. So this is a left bundle branch block ECG, and that's probably the quickest way to differentiate or determine that there is a bundle branch block. What about this one here? Let's pause the video. Okay, and we're back, and so this one here, looking across the rhythm, it's a sinus rhythm, so on and so forth. All that aside, since we're talking about blocks, we can see that V1 and V2 have the RSR prime, especially V1, there's an RSR prime pattern. And typically with a right bundle branch block, you should see S waves in the lateral leads and V5, 6, and limb lead 1 and AVL, but you don't see it here, so this is not a perfect example. But it is a widened QRS greater than 120 milliseconds, and there's an RSR prime pattern, which makes us think that there's a right bundle branch block. Now, whenever you see a right bundle branch block pattern, look at your axis. If there's a left axis deviation, there's also a left anterior fascicular block. If there's a right axis deviation, there's a left posterior fascicular block. And here we have a normal axis, so this is just a right bundle. Okay, let's talk about AV nodal blocks. So there are different types of AV node blocks. There are different degrees of AV node blocks, and then different types within the second degree AV node block. So the first degree AV node block is defined by a prolonged PR interval. Again, interval includes the wave, so it includes the P wave. So greater than 200 milliseconds or zero point 0.2 seconds, or one large box. So here's a large box, and as you can see, the PR interval extends beyond that. Typically, this is asymptomatic and there's no treatment that's needed. As you can see, the PR interval does not change with every beat. It's about, I don't know, you can say 8 small boxes in duration, and it doesn't change across all the beats. So this is a first-degree AV node block. In a second-degree AV node block, it's divided into type 1 and type 2. This is an example of type 1. There is some colloquial terminology or nomenclature that we also still use to describe type 1 and type 2. So this is was often referred to as the Winky Bach, and the type 2 is referred to a Mobitz. However, some texts or some people may call type 1 a Mobitz 1 and type 2 a Mobitz 2. So if you're going to call type 1 a Winky Bach, then you should call type 2 a Mobitz without putting a number on it. If you're going to call type 1 a Mobitz 1, then you should call type 2 a Mobitz 2. Or you could just call it a second degree AV node block type 1 or type 2, and you don't have to worry about the colloquial nomenclature that sort of medicine is shifting away from anyways nowadays. So in a second degree AV node block type 1, also known as a Winky Bach, the PR interval gets progressively longer and longer until there is a P wave that's not conducted, or there is a dropped QRS, as we say. The mechanism for type 1 second degree AV node block is typically vaguely mediated, and there's no actual pathology within the AV node. So you will see this if patient has parasympathetic stimulation, they're vagling, they're post-operative, and they just got extubated, so on and so forth. You may see this. Now, the other important thing when you're looking at these type 1 second degree AV node blocks is that they occur in group beatings, so the rhythm overall will be regularly irregular because you'll have 3 grouped beats with a dropped P wave here, or a non-conducted P wave, and then another group of 3 beats, and then another non-conducted P wave. So whenever you see group beatings, look at your PR intervals, make sure that they're not prolonging. If they are, it may suggest that there is a type 1 second degree AV node block. And that's probably one of the biggest key points, is the group beating. So I think about Winky Bach is, the way that I remember it, is the winking Bach. So this is Bach and he's winking at you, and this is it's telling you that there's progressive prolongation of the PR interval, and it's a wink or a hint that a dropped QRS is coming. So that's one way to remember what a Winky Bach is from the Mobitz. And so a second degree AV node block type 2, or a Mobitz 2 if you're going to call type 1 a Winky Bach, is when not every P wave is conducted and has a QRS attached to it. There may be different ratios, so you may have a 2-to-1, a 3-to-1, 2-to-3, and so on and so forth. So here is an example of 2-to-1. You have 2 P waves to every QRS, and then 3-to-1, you have 3 P waves to every QRS, and so on and so forth. And the higher the degree and type of these AV node blocks, the higher the pathology and the worse it is, and the more that you need to do for them, and closer monitoring, and so on and so forth, and chance of arrhythmia. A third degree AV node block, which is also known as a complete heart block, this is the worst one of all, is when there's no communication of electrical activity from the top chambers to the bottom chamber. So there's dissociation of the P waves and the QRSs. So the P waves are marching through at their own pace, whatever the inherent atrial rate may be. As you can see here, the P waves are denoted by the letter P, and they're marching through regularly at their own pace. And the QRSs are also marching through at their own rate, either if it's coming from the ventricles and it's slower, or it's coming from the junction and it's a junctional escape rhythm and it's a little bit faster than what would come from the ventricles. But the key here is that the P waves are marching through at their own pace, and there is complete dissociation between the P waves and the QRS complexes. And so you can see a P wave here right before a QRS. This one here is after the T wave. There's a P wave here falling within the ST segment. Sometimes you'll see a P wave within the QRS. And this is a complete heart block. So symptomatic second degree type 2, persistent second degree type 2, second degree type 2 block with a bundle branch block, such as a left bundle or a right bundle, or a right bundle with a left anterior fascicular block. All of these, a third degree AV node block, all of these need a pacemaker, most likely. Third degree AV node blocks, this is sort of a board question. These can be caused by Lyme's disease. So if you get a question stem about a patient who is from the Northeast and was hiking, and they're coming in with severe bradycardia and syncope, and they show you an EKG and it looks like a third degree AV node block, think Lyme's disease. And one quick tip, so if you have an AV node block and a right bundle branch block and a left anterior fascicular block, oftentimes people refer to this as a trifascicular block. It is a misnomer because it's not there are no three fascicles that are blocked. The AV node, it's sort of like a bifascicular, a right bundle and a left anterior fascicular block, a bifascicular block plus an AV node, and sometimes people refer to it as a trifascicular block, and that's obviously bad. If you're literally living off of your posterior left posterior fascicle, and that's the only thing that's conducting electricity to the entire heart. So this is a practice. Let's pause the video here. Okay, and so this is an easy one because the numbers are sort of there. But the first striking thing is when we look at the rhythm strip at the bottom, limb lead 2, we see a regularly irregular rhythm. On a regular basis, there's irregularity. There are group beating of QRSs, so there's 4 beats followed by a gap, and then 4 beats, and then followed by a gap, and the rhythm continues. So automatically you should think about second degree type 1 second degree AV node block. And if we look here, they obviously gave us the numbers, the duration of the PR segments. So it makes it easier, but even visually, if you were to ignore the numbers, you can see that the PR interval is about just over, one large box in duration, then it gets longer, then it gets longer and longer, and then finally you have a P wave here that is not conducted, and then the cycle restarts itself from beginning, from the beginning. So this is a type 1 second degree AV node block. Let's pause the video here. Okay. So what does this one look like? This one also is a regularly irregular rhythm, so you should automatically think that there's a second degree type 1 AV node block. But this one is actually a second degree type 2 AV node block. The PR segments are not prolonging as you would suspect, or as you would expect in type 1, but you have a P wave that's not conducted. So this is a intermittent 2-to-1 block, essentially. So you have 2 P waves per QRS, and it's intermittent. Moving on, and if you want to pause the video here. So this one here, looking at the rhythm strip at the bottom, it's a little confusing at first glance. There's no group beating. It's very regular. The QRS complexes are regular. But the atrial activity at the baseline, you see P waves, but some QRSs don't have P waves. Some of them that have a P wave after the T wave. Here's a P wave within the QRS. So it makes you think that there is dissociation here of the atrial activity and the P waves and the QRSs. And then you think to yourself, well, I thought that the QRS escape rhythm, the ventricular escape rhythm, was supposed to be wide. And that's true if it's coming from the Purkinje fibers, but you can have an escape rhythm from the junction, and it could be narrow complex, as it is in this situation. So this is a third degree AV node block, and the P waves are marching through at their own rate and pace, and the junctional escape rhythm is going at its own rate. So whenever you see discordance or dissociation of atrial and ventricular activity, but the ventricular rhythm is regular, this is another one of those tricks up your sleeve. It should make you think about a complete heart block or third degree AV node block. The other I guess tip that I have for you, so the way that you would read this EKG is that this is a sinus rhythm with a third degree AV node block and junctional escape rhythm. So it is a sinus rhythm because the beats are coming from the sinus node, the P waves. It's not a normal sinus because not every QRS has a P wave behind it, but it is a sinus rhythm with a third degree AV node block and a junctional escape rhythm. Okay, so that's how you would read all of these EKGs. All right, so here's a little bit more clarification on the 2-to-1 AV node block. So if you have something that looks like a 2-to-1 AV node block, so you have two P waves and a QRS, two P waves and a QRS, it's difficult to determine, is it a Mobitz type 1 or Mobitz type 2? Is it a Winkie-Bach or a Mobitz? So is the PR interval here, let's say, one large box in duration, and the next one gets so prolonged that it doesn't conduct a QRS, and then the cycle starts all over again? Or is it that there are two P waves per QRS, like a type 2 Mobitz? Or even in this picture, is it a third degree AV node block? Is it a complete heart block and the P waves are marching through, and it happens that the rate of the ventricle, the ventricular or junctional escape rhythm in this situation matches the rate of the atrial activity by half so well that you don't see P waves falling on top of the QRSs and the T waves. So there are things that you can do to help you differentiate the rhythm, obviously. One thing that you can do when it's in question is you can do a vagal maneuver. So when you do a vagal maneuver, you have to think about the physiology. When you do a vagal maneuver and you increase parasympathetic activity, I told you that the AV node is susceptible to sympathetic and parasympathetic tone, as is the sinoatrial node. So if you do a vagal stimulus or maneuver, and the ratio becomes a 1-to-1, so 1 P wave to 1 QRS, then this is a Mobitz type 2. Why? Because in a Mobitz type 2, second degree Mobitz type 2, there is probably intrinsic disease of the AV node. And so when you perform a vagal maneuver, it's not going to respond to the vagal maneuver, but the sinoatrial node will respond to the vagal maneuver, and it'll slow down the P waves so that now it matches the QRSs at a 1-to-1 ratio. If you perform a vagal maneuver and the ratio, the 1-to-1 or 2-to-1, whatever it is, if the ratio worsens, meaning it becomes greater, 3-to-1, 4-to-1, 5-to-1, then it's a Mobitz 1, it's a Winkie-Bach. Why? Because that means that there's no intrinsic disease within the AV node, it's sympathetic tone, parasympathetic tone or vagal tone that's driving the block. And if you deliver more vagal tone and more parasympathetic tone, then you're going to worsen the block. So you'll have more P waves per QRS, and so that's something to keep in mind here. You can do the opposite with exercise ECG. So if you exercise these patients and you increase their sympathetic tone and the ratio becomes a 1-to-1, then this is a Mobitz 1, a Winkie-Bach, because you're removing the or you're fighting against the parasympathetic and vagal tone on the AV node, which is the primary issue in Mobitz 1 or Winkie-Bach. And so you're improving that, and it becomes a 1-to-1 ratio, 1 P wave per QRS. If the ratio worsens, then it's a Mobitz 2, because the AV node is intrinsically diseased, and as you exercise, it's not going to respond to the exercise and increase its conduction rate, but the sinoatrial node will increase its rate, so therefore you'll have more P waves per QRS. And so the ratio worsens. And so this tells you that the AV node is not responding, so it's a higher degree block. It's a Mobitz 2 probably. So if these two are sort of the opposite of each other, the vagal maneuver and the exercise ECG. Um, this is the question that we've all been waiting to answer, and this is what I was mentioning before. Is this ventricular tachycardia or is it supraventricular tachycardia with a left bundle branch block? Both of them would be a wide complex arrhythmia, um, a wide complex tachycardia. So how do you differentiate the two? Because you may treat it differently. Um, so this is actually SVT, supraventricular tachycardia with a left bundle branch block. And if it were to be ventricular tachycardia, these are the things that should make you think that. And this is called Brugada algorithm, not to be confused with Brugada syndrome. And what the Brugada algorithm tells us, and I'll show you, I think I have a slide where it shows you the actual algorithm. But if you don't see RS complexes in V1 through 6, you only see R waves or you only see S waves across all of the precordial leads, and we call this concordance. They're all concordant, going in the same direction. This should make you think VT. So the reason for that is if you have an impulse coming from the apex of the heart, ventricular tachycardia coming from the apex of the heart, all the precordial leads, V1 through V6, are going to see that beat coming from the same place up towards them. So all of your QRS complexes will be deflected in the same direction. But if an electrical impulse is coming from the top chambers and it's going down the normal pathway, then you will have discordance, or you would have a normal R wave progression across the precordial leads. V1 and V2 will be negative, V3, V4 will be isoelectric, V5 and 6 will be positive deflected, so on and so forth. So if they're all pointed in the same direction, either up or either down, then it should make you think VT. Here we see again, V1, V2, even V3 a little bit. That's the transition point that's trying to happen. These are V1 and V2 are negative, and V3, V4 is a transition point, and V5 and V6 are positive. So there's discordance, there's R wave progression, makes you think that this is SVT. If the RS interval is greater than 100 milliseconds, so if it's wide and bizarre, wider than this, and it looks a little bit more bizarre, then it should make you think VT. There's AV dissociation, atrioventricular dissociation. So you may actually, if it's not going this fast, you may be able to see P wave activity from the top chambers. And if there's a P wave before each QRS, or there's a P wave right after each QRS, making you think that this is an SVT. But if there is no association, there's dissociation of the AV conduction. So you have a P wave, what appears to be a P wave on top of a QRS or a T wave, that should make you think that there is ventricular tachycardia, because the ventricles are going at their own rate, regardless of the atrial conduction. If there is an absent typical bundle branch block pattern in V1, that should make you think that this is ventricular tachycardia. So in this example here, we see a deep S wave, widened deep S wave in V1 and V2. We see upright R prime looking almost. If you were to, I guess, zoom in, you could see the RR prime here in V4. So you have the findings of a left bundle branch block. And similarly, you should look for findings of a right bundle branch block. All of those should be clues. And if you don't see that, then you should think VT. And again, the R prime, if there's a right bundle branch block looking pattern, if the R prime is smaller than the R, so if the second R wave is smaller than the first R, it should make you think VT. If the second R is larger than the first R, remember that's in a right bundle branch block. So right bundle branch block, second R is larger than the first R. In VT, you may have the opposite finding. And then finally, if there are capture beats and fusion beats, and I'll show you an example of that. This is a capture beat here. You have ventricular tachycardia, and one beat from the top chambers from a sinus beat will capture through all of that arrhythmia. It'll actually come down at the right time when there is refractoriness happening, and it captures right after refractoriness, and you get a sinus beat along all of this ventricular tachycardia. So why does that make you think there is VT? Well, because if this was SVT, there is no reason why one beat would look normal, nice, narrow, QRS complex with a P wave and a T wave. It would just look all like SVT. So there's something that broke through the ventricular rhythm, and that's called a capture beat. Here is a fusion beat. The fusion beat is sort of a mix of the two, from a mix of the ventricular tachycardia beat and a sinus beat, so it looks a little bit different. So capture beats and fusion beats should make you think ventricular tachycardia. Here's the concordance and discordance I was talking about along the precordial leads. So all of these waves are upright across V1 through V6. Should make you think ventricular tachycardia. All of these waves across V1 through V6 are negatively deflected. Should make you think ventricular tachycardia because there's no R wave progression normally. And look how this one here, the QRSs are wide and bizarre, and there's notching of the QRS complexes. That also should make you think that, and it's very wide. It should make you think that this is ventricular tachycardia. The left ear, so the R prime is larger than, the R is larger than the R prime. This should make you think ventricular tachycardia. However, in a right bundle branch block, the R prime is larger than the first R, as shown here. The R on the right side is larger, and that's a right bundle. So these are some clues essentially to help you differentiate VT versus SVT with a left bundle. If you have a wide complex arrhythmia, tachyarrhythmia, and it's irregular, you should always think that this is atrial fibrillation with either a left bundle or with aberrant conduction, meaning that there's aberrancy and no good, succinct conduction through the normal conduction system. There's aberrancy conducting the electrical current conducting down to the ventricle. So irregular wide complex tachycardia, think about atrial fibrillation with either a left bundle, right bundle, or aberrant conduction through the myocardium. And that's because monomorphic ventricular tachycardias are often regular, most times, if not always. So special disease states, Brugada syndrome, again, not to be confused with Brugada algorithm. Brugada syndrome is an inherited arrhythmia. It's dysfunctional sodium channels, essentially. It can cause sudden cardiac death and cardiac arrest, VT or VFib in a young, healthy individual. So the two ways that young, healthy individuals die on board exams is either by in their sleep, and it's due to an arrhythmia, and the answer would be Brugada syndrome, potentially, or Wolff-Parkinson-White or something like that, or they die while playing basketball or football on the field, exerting themselves, and that's hypertrophic obstructive cardiomyopathy. So that's something to keep in mind. But Brugada syndrome is an inherited arrhythmia, as I mentioned, and the pattern that you see is a right bundle branch block looking pattern on ECG in V1 through 3. So you see RSR or an RR prime, like a rabbit ear finding. And then there's this weird sort of ST segment elevation and downsloping. It's kind of like the convex ST elevation, tombstoney almost, but it looks kind of weird. And there's a right bundle branch block pattern as well there. This is seen in type 1. There are 3 other types, but type 1 is the most common one. Significant T-wave inversions, I think this is important to recognize. So the first one is Welland syndrome. This is the most important one. This is caused by a critical left main critical left anterior descending coronary artery stenosis. So patients who present in the right clinical setting with angina, who have an ECG that shows either a biphasic or markedly inverted T wave that's sort of deep, can even look like this bottom image sometimes in the anterior leads. You should be cognizant of this and be wary that they may have Welland syndrome. And these patients will develop a large anterior MI from the widowmaker, from the LAD, within the next days to weeks. So it's important to catch this and not write it off as acid reflux or negative enzymes. This is just angina. Go see your cardiologist for a cath 2 months from now. And then this pattern of T-wave inversion, these deep T-wave inversions, if they're seen in the lateral leads in V5 and 6, this should make you concerned about apical hypertrophic cardiomyopathy, where the apex is hypertrophied only. And so I think about it as V5 and 6 being over the apex, and they're deeply inverted, and that's how I remember that these are associated with apical hypertrophic cardiomyopathy. Sick sinus syndrome is where the sinus node is dysfunctional and there's a failure of the escape rhythm. So the entire conduction system is essentially diseased in a way where there's a failure of the escape rhythm to assume the pacing responsibility. Highly conditioned marathon runners have hyperparasympathetic or parasympathetic hyperactivity at rest and may present with a pseudo-sick sinus syndrome, and their heart rates are in the 50s, and they may have these blocks, what looks like there's a block, and that's fine, that's normal. And then bradycardia tachycardia syndrome, or SSS, this is an SSS variant, and patients with SSS may actually present with episodes of tachycardia and bradycardia. So it's sort of like a spectrum disease in a way. This is an example of that. Sinus rhythm, there's a pause here, asystole, and then tachycardia. So bradycardia tachycardia syndrome, variant of sick sinus syndrome. Pericardial diseases, acute pericarditis. So these are some of the ST elevation patterns that you see that are not concerning for myocardial infarction. They are the strain pattern, or the upsloping or the concave ST elevation. So you have on ECG diffuse concave ST elevations in all of the leads. Diffuse means in all the leads, with the exception of AVR. In AVR, you should see reciprocal ST segment depressions, and you may also see that in V1 as well, because V1 and AVR are sitting on the right side, so they see the exact opposite of every other lead. So you'll have ST depressions there in those two leads, but every other lead has ST elevations that are sort of concave looking, like the smiley face. And the ST segment elevation should be greater than 25% of the height of the T wave in V6. I know this is lead 5 I'm showing you here, but that is sort of a minor criteria. I guess I don't even know if it's a criteria, but this is something that's sort of minor. But the other major thing is that you should have or you may see PR segment depression. Again, the segment is depressed, the PR segment is depressed in all of the leads, the majority of the leads. And in AVR and V1, where everything else is opposite, than the other leads, you may actually see PR segment elevation with the ST segment depression. So if you find these, if you see these findings on ECG, patient coming in with chest pain, it's a pleuritic chest pain, you should think about pericarditis. Now, the resolution of EKG changes and time order. Within the first week or so, there's going to be normalization of the ST segment elevations. Then the week after that, approximately, you'll have T-wave flattening, and then the T-waves will sag down and become inverted. And then over the course of the 4th week or so, the ECG returns to normal. And that's important to recognize the resolution of the ECG changes, because a patient may come back being treated as an outpatient for pericarditis, may come back with chest pain, and a repeat EKG shows T-wave inversions. May not be that they're having ischemia, but it's just the normal resolution of the ECG changes. Pericardial conditions continued. So cardiac tamponade and pericardial effusion. the clinical findings that you would see is tachycardia, obviously, especially in cardiac tamponade, as the heart is not able to fill and therefore not able to eject any blood, and the cardiac output drops. The body's response is to increase the heart rate to compensate. So you'll see tachycardia. If there is obviously fluid around the heart, you may see low voltage QRS complexes, especially across the precordial leads. And then there's a finding called electrical alternans on ECG. And that's that the QRSs will alternate in their height. And this is, again, not to be confused with that biventricular tachycardia that's seen in digoxin, but you see alternating height or voltage in the QRSs. This is another even worse example of it here. They're alternating voltages across the leads for the QRSs. And so the reason for it is that the heart is actually suspended in the pericardium in the sac, and it's attached superiorly to the great vessels, and it's hanging and dangling in the sac. And basically, when there's a lot of fluid within the pericardium, the heart will actually, with each beat, it's swinging back and forth, and so you get the different voltages, the alternating voltages with every beat. Benign early repolarization is another condition, if you will, that has ST or J point elevation that looks like a strain pattern, again a smiley face rather than a sad face or the tombstoning. It's seen in young patients. The physiology is not really well understood, doesn't signify anything, and sometimes can be confused with pericarditis or STEMI if a patient comes in with chest pain. So the history is very important. Is it an anginal chest pain or is it a sharp pain? But you'll see across the precordial leads, you'll see this J point elevation, an upsloping sort of ST segment elevation. That's benign early repolarization. The ST segment elevation should be less than 25% of the T wave height in V6. Greater than 25% is the pericarditis one, although that's not a very strict criteria. And the changes are stable over time, so many years they'll have it. Moving on to the Osborn wave, or the J wave. This is another example of an ST segment elevation or a J point elevation that is not ischemic. This is typically seen in hypothermia, so the clinical situation is important again. You have a positive deflection at the J point immediately after the QRS and an ST, sort of a concave ST elevation. So the way that it presents is a patient who was stuck in their car under a pile of snow, for example, and is coming in hypothermic, or a patient had cardiac arrest and they're being cooled now, and they start having these J point elevations and ST elevations, and it's called the Osborn wave or the J wave. So let's pause here and go through this example. Okay, so what does this look like? By this point, you should be able to read the 12-lead ECG completely. So you look at limb lead 2 and you get your rhythm, rate, and axis. And then there are some obvious changes here with the ST segments, but feel free to practice and go through and tell me if there are any left ventricular hypertrophy, right ventricular hypertrophy, or any sort of atrial dilatations. Are the PR segments and QT is the QTC normal, so on and so forth. But I think what's obvious here are the ST segment elevations across all of the leads. So limb lead 1, limb lead 2, 3 doesn't have any ST segment elevations, but AVF, so the inferior leads have ST segment elevations, and look at the morphology of them. There's sort of the strain pattern, the upsloping ST elevation, AVL across the precordial leads, and then V1 and AVR have ST depressions. And if you look for the PR segment, you see that the PR segment is elevated in AVR, and in all the other leads, the PR segment appears to be depressed below the baseline slightly. So this is pericarditis. So pulmonary diseases, pulmonary embolism. The most common finding on ECG is sinus tachycardia, and that's because of an obstructive shock because of the pulmonary embolism and the right heart strain and decreased cardiac output and all that kind of stuff. That's the most common finding. You may also see right axis deviation because of the RV being ballooned out. If it's chronic pulmonary embolism, the RV may be hypertrophied. There may be a transient right bundle branch block because of the strain. And then there is this finding that's specific for pulmonary embolism, but it's very rarely seen on ECG. And it's where you have an S wave in lead 1, ST depressions in lead 2, and a large Q wave with T wave inversions in limb lead 3. So this T sort of moved up here on the slide, but we memorize it and we say it as S1Q3T3, and the T is inverted here to help with that. So S1Q3T3, if you have that finding, an S wave in 1, Q wave in 3, and inverted T wave in 3, it's specific for PE in the right clinical situation or setting with hypoxemia and tachycardia and hemodynamic compromise potentially and pleuritic chest pain. And it should make you think pulmonary embolism, but it's just not very frequently seen. In COPD, you may see low voltage amplitude in all the leads, and also right axis deviation because of the pulmonary hypertension from the structural changes of the lung from the COPD, and the right ventricle over time becoming either dilated or hypertrophied. The other condition that causes low amplitude, and I guess before I go and move forward, the reason why you have low voltage in COPD is because of the barrel chest sort of patients, that the heart is sitting so far away from the ECG lead on top of the chest, and there's so much air in between from the damage to the lungs. Another condition that has low amplitude or low voltage amplitudes in the leads, especially in the limb leads, first is amyloid, cardiac amyloidosis, where the heart is thickened because of the deposition of the protein, the abnormal protein deposition. So you think that it's hypertrophied, and you should have QRS complexes that are very high in voltage amplitude, like left ventricular hypertrophy. But really, because of that protein deposition, you'll have decreased voltage amplitude, similar to this one actually. So pacemakers, very quickly, there are many different types of devices: single chamber pacemakers, dual chamber pacemakers, CRTDs, cardiac resynchronization therapy devices with a defibrillator or a pacemaker function, which is essentially a 3-chamber device. But these are some simple examples here to make you familiar with pacemaker stimuli. So this is a rhythm strip where you have a pacemaker stimulus immediately followed by a wide QRS complex. There's no P wave activity here that we see, so we know that this is a single chamber ventricularly paced rhythm. So the pacemaker lead is sitting at the apex of the right ventricle, and so you have a right bundle. So you'll see what looks to be on a 12-lead ECG to be a left bundle branch block pattern. Why? Because the pacemaker is pacing the right ventricle first, then the conduction travels more slowly towards the left side as it would in a left bundle branch block. So you'll have deep S waves in V1, V2, V3 on your 12-lead EKG with a RV pacemaker, single chamber pacemaker. This one here is an atrial paced rhythm. So the pacemaker lead in the atrium is what's pacing here, and the AV node is normal. So you have a pacemaker stimulus followed by a P wave, and notice how the P wave is notched and sort of widened. That's because the right atrium is paced, and then the current travels towards the left atrium in a more slow fashion, in a more delayed fashion. And then some of that is obviously conducted down to the AV node and to the ventricle, so you have a nice narrow complex QRS as you normally would. So this is an A-paced rhythm. So moving on, one word electrolytes. We've sort of touched upon some of this already, but hypokalemia, calcemia, and magnesemia, I think about not enough electrolytes to allow for normal depolarization and repolarization. Therefore, everything is prolonged, especially the QT. Whereas hyper is the opposite. I sort of think about it that way. So in hyperkalemia, you'll have peaked T waves. That's the key word that you need to know. Peaked T waves in hyperkalemia. For example, renal dysfunction, end-stage renal patient with hyperkalemia, and as soon as you see peaked T waves on ECG, that's a big deal. You need to give them calcium gluconate, and you need to this is an indication potentially for dialysis to try to bring the potassium down. You need to treat it and temporize them until they get dialyzed. In hypokalemia, you'll have flattened T waves, a long QT, and sometimes you'll even have a U wave because repolarization is delayed so long. Hypercalcemia, you may see a shortened QT as shown here. And then hypocalcemia, again, long QT. And you should look out for torsades. But really, hypokalemia is the most dangerous one and can lead to torsades, torsade de Pont. Hypomagnesemia, not so much. Hypocalcemia can as well. But hypo, long QT. Differential for T-wave inversion, this is just an FYI slide. Myocardial infarction and ischemia we talked about already. Myocarditis, viral or from whatever etiology, can cause T-wave inversions and ST segment changes. And the one that I think sometimes can show up on boards is Friedreich's ataxia. The people who have the high arched feet and ataxia can oftentimes or do oftentimes have a higher propensity for developing myocarditis. So they may say patient with Friedreich's ataxia or the physical exam findings of that disorder has T-wave inversions and chest pain. And what is it? It's myocarditis. Old pericarditis, while resolving, again, we mentioned in the third week we'll have T-wave inversions, approximately in the third week. Myocardial contusion, because of the damage to the cells, think of it as similar to an infarction. Digoxin toxicity can have T-wave inversions, as I think there's a slide coming up on that. And then intracranial pathology, especially increased intracranial pressure, can cause diffuse T-wave inversions across all the leads. So digitalis, the mechanism of action. Digitalis is an oral inotrope, and it works by inhibiting the sodium-potassium ATPase, and thereby it increases concentrations of sodium within the cells that then inhibit the calcium-sodium exchanger right next door to it, and this leads finally to an increased cellular calcium level and via calcium-induced calcium release and the ranitidine receptors and so on and so forth. There's enhanced contraction and contractility, and that's how it's a inotrope. But excessive digitalis can cause AV node blocks, sinoatrial node blocks, escape rhythms to occur, and most commonly you'll see tachyarrhythmia, such as an accelerated junctional rhythm. That's the most common one, and then the oddball, which is the biventricular tachycardia that I showed you an example of. And what you'll see on ECG is this ST segment depression and T-wave inversion that looks like the mustache of this guy here. All right, so the final practice ECG is this one here, and I'll give you all a couple seconds to pause the video and tell me what condition gives you this ECG, or what situation, clinical scenario gives you this ECG finding. Okay, and this is your ECG when you're on a roller coaster and your heart drops. Obviously, I'm joking, but I hope you enjoyed the 4-hour ECG series. Give me feedback in the link below in the survey, and if you're interested, subscribe to my channel and watch some of my videos. Unfortunately, this year I wasn't able to provide this lecture live, which I typically like to do, but if you have any other questions, feel free to contact me and I'll be happy to answer them for you, and best of luck.